Hi everyone, this is Professor Butler, and here is your lecture or your lesson on child with a GU dysfunction. This is going to be relatively short. Some of this is going to be review for you. We're going to touch on about 4 or 5 different types of GU disorders, specifically that we see in children. We're also going to talk about some congenital issues and then wrap up talking about the 2 types of dialysis, peritoneal dialysis as well as hemodialysis. These are your lesson objectives as well as your readings. There are some areas in the readings that are in different chapters, I believe. Let's see, so mostly, you have your GU chapter, but we are going to review some of the stuff from your fluid and electrolytes as well chapter. So as usual, characteristics of urine, we all know this. The darker the urine usually represents the more dehydrated, more concentrated the urine is. We obviously want it to be in the good range or the fair range. I try to stay away from the very good, that it's clear, because that can also mean some other issues as well. So I would always recommend that we want the characteristics of the color to be good or fair. Just as a reminder, in children, we like to look for 1 ml per kilo per hour of output. Infants can have a little bit more because they are taking in mostly fluid, but in all, we want it to be 1 milliliter per kilogram per hour. You do need to review how to calculate output as well as the maintenance rate for children, because you are going to see that again on this exam. So we're going to talk about a little bit of the differences in children. The urethra is shorter in females. That is relatively the same even in adulthood. Men have a 10 times longer urethra. So it puts us at more risk for an infection. The kidneys for children are larger and less protected. Therefore, they're more prone to kidney injury or trauma. When children are born or infants are born, the kidneys are immature and are less able to concentrate urine. They also lose fluid more easily, so they become dehydrated as well. That's kind of referring back to the other chapter that we talked about, some of the reasons why infants specifically have greater heat loss, thermoregulation issues, as well as fluid loss. The bladder capacity usually starts around 30 milliliters per hour. 30 milliliters for an infant. And then it can increase as large as 500 to 1,000 milliliters capacity as they grow into adolescence, which is also considered adulthood. Some of the issues that children have to deal with being incontinent or having poor hygiene habits, specifically directed towards UTIs. And so a lot of our teaching and a lot of our nursing management is going to be around teaching them how to wipe properly, how to not hold their urine or their stool, and just some of the things that we need to look out for when children are showing us signs that they might have an infection. Okay, so next we are going to, let me click to the next slide. So the review of the kidney. I'm not going to go into detail because I feel like I can't do it as good justice as Khan Academy. On the next slide, you will see a link to review of the kidney. It's not one of my biggest specialties, but he does a very good job of reviewing the anatomy of the kidney. It is something that you do need to know, not necessarily for the tests, but for your understanding. And I think it's one of those complex systems, so it's good to do a review. Again, it is optional. If you feel that you have a strong understanding, you don't need to view this video. There's another video later on in the presentation that goes over the glomerulus, and I think that is a great overview. I don't feel like your book does a really good job of explaining and reviewing it to the point that you really go into detail about the space in the Bowman's capsule, because that's really a lot of where you see your I don't want to say variances, but really where you see your problems when you have inflammation in particular structures within that Bowman's capsule, as well as the glomerulus. When we get to those disease processes, that you need to have an understanding of like what's generally going on there. You don't need to be specific and know the different pressures and so forth, but you need to have an understanding of what's passing through, what's being filtered, so that, and what different layers of linings are within the Bowman's capsule or also within the space. So you need to kind of have an understanding of that. And I think it'll make things so much easier when you're trying to decipher whether or not you're looking at this versus that. So please take some time to review if necessary. All right, so with the renal system assessment, you know, we always talk about a focus assessment or just how we approach an understanding of what's going on from a pediatric standpoint. We obviously want to do an inspection and palpation. Particularly in our males, we want to, when they're first born, if you've been able to see a really good assessment of a newborn, we should palpate the scrotum to see if the testes have been descended. If it's not, and we'll talk about that later, sometimes we do have some conditions they can descend later on, but we do need to have a close monitoring and make sure that that does happen. You also need to inspect the penis gland to see where the urethral opening is, because we have some alterations in that could happen. For our females, we definitely need to make sure that they're voiding, make sure that they're actually urinating correctly. And then also for going back to the boys, you need to make sure that you can retract a foreskin. We never want to force it. And we also want to see if there's any pain associated by looking at the infant's face. Let's see, so health history, for our older children, we want to see if there's any previous urinary tract infections. Are there any for our adolescents or our school age? Any sexually transmitted disease histories, any bladder dysfunction. Sometimes people forget to tell you that their child has one kidney. We've had that happen before. That's important to know. There may not be any alterations, but the fact that the child only has one kidney is very important to know. Are they on any medications that could actually affect the kidney? Any medications that need renal clearance, right? What are some medications that they're on that could be related for any type of renal issue that they have going on? Urinary hygiene. Some of the questions that you need to ask about that is, you know, how do they wipe themselves? Before you even get to that, I would ask, are they potty trained? Are they using the bathroom independently? Are we monitoring how they are cleaning themselves afterwards? And kind of lead up to that. Because if you go directly to that, the parents are obviously going to say, of course they do it right. All right, so can you explain to me? Older children are going to get very nervous if you ask them directly. So you kind of want to start with the parents and then you want to go to the child if necessary. If you get an opportunity to see it, that's great, but usually children will not let any strangers, especially if they're preschoolers or school age, to be able to see them do anything. Of course, with our adolescents, you can be direct with them. And what are their patterns of elimination? Are there any accidents going on, bedwetting going on? Do you know the characteristics of their urine output? Stuff like that. We do need to ask and see whether or not the family can give us some clues of what's going on. So next we're going to talk about some diagnostic studies. Renal scans, cystogram, basically these are all ways that we're scanning to see if there's anything going on in the urinary tract system. Cystogram specifically looking at the bladder. A VCUG or VCG is basically an injection of dye and seeing how the dye goes through and comes out. Do we have any obstructions? Is there any reflux going on? So this voiding cythourethrogram, I think I said that correctly. Well, we just say VCUG, is a good test to see the flow of urine from the kidney down to the bladder, and then ultimately emptying out of the system properly. CT, MRIs, we all know what that's about, but sometimes when we do that, we're not necessarily looking at urine, we're looking at the structures. We're looking at getting a clear understanding of any inflammation, any type of infection, any type of cyst. Cysts naturally do grow on kidneys, and as long as they're not having any issues, we won't do anything about them, but sometimes they do rupture. Urinalysis, urine cultures are straightforward. BUN and creatinine give us a clearer understanding of the function of the kidney. And then a KUB. KUB, as you know, looks at the abdomen, the kidneys, and the bladder. So we want to kind of get an idea just from an x-ray standpoint if there's anything going on, and then we can go to some more expensive and then invasive tests. So these are the tests that we do use for GU or renal dysfunctions. Okay, so circumcisions. So we do need to talk about circumcisions just for a little bit. It actually can be completed at any age. It is an optional procedure if a family has a boy, and usually a lot of people do circumcision, but increasingly it's getting to the point where sometimes do not do it, and there's many reasons why they do and they don't. So I've listed here, it's mostly done sometimes for religious reasons. In some religions it can be delayed till they get a little bit older. Also hygiene. So a lot of times they say, you know, females are supposedly getting UTIs more because we're more at risk. However, they're seeing boys getting UTIs more than females, and this is probably mostly because of the fact if they're not getting circumcised, they're also not retracting the foreskin and cleaning well, and that is causing them to have more UTIs according to several studies. So that hygiene is really, really important if a child is discharged from the hospital and they choose not to have a circumcision done. So that needs to be in the discharge education. Cosmetic, sometimes I think is one of the big ones that I've seen, is because they don't, first of all, they don't want to deal with it when they leave, and then they also do not want their child to not look like daddy. So and so they know that circumcision is something that needs to be done. I will also say some insurance companies have started not paying for it. So this is sometimes a barrier if a family wants to have a circumcision, that insurance companies realize that this is an optional procedure. And I don't know if the cost is higher in an acute care center versus getting it done in an outpatient center. But there's a little bit of a shift due to some insurance reasons, which I think is not a good idea. And the last reason I have listed here is preventing health-related reasons. There are some conditions that can happen if a child does not have circumcision done. It puts them more at risk. And one of them is they can actually get adhesions, you know, the UTIs and so forth. So sometimes they just do it just because of that. Now, in order for a circumcision to be done, they have to have enough foreskin. And if a child has a condition where they don't have enough foreskin, then it's going to have to be delayed. And at the top, you don't need to know this, but there are several different methods on doing a circumcision, and I believe I have a video for you as well. So the most popular that I've seen is the bell, the plastic bell, which is the one here at the bottom to the right. And that bell is there to protect the gland, because if there are some issues and somebody cuts in the wrong way, they can actually really do some damage to the penis. And I've seen some really bad circumcisions, and it was pretty horrifying to see. Then I really hope the family did something about that. Anyhow, so circumcisions are done. Usually they don't need any anesthesia or anything like that. Usually infants will have sucrose and a pacifier, and some physicians will still numb the area. If I was a parent, I would say you are going to numb the area, just for the comfort of the child. After circumcision, you do need to make sure that the child is able to void. So that's one of the nursing management that we will assess and make sure the child has a wet diaper after a circumcision, so they can't go home until we see that happens, because circumcisions usually are done right before discharge. Another thing is they stop putting the Vaseline at the top, or antibiotics. A lot of people want to put, because they think it's a wound because it's red and it's inflamed. If it's the bell, usually, they can still see the bell on top, and it will naturally just fall off as it heals. And we need to explain that to family members. It's not going to hurt anything if they do put antibiotic ointment. It's not going to hurt anything if they do put a gauze and Vaseline. It's really just to kind of protect it from any type of oozing that happens, and it kind of, it gets, it might get stuck to the diaper, and so we don't want the child to have that type of discomfort. Or we can give them some Vaseline gauze, and we can just put the Vaseline gauze on top. It really is not going to hurt anything if people want to do that, but they've moved away from that because they feel like it's not necessary. The most important thing is to make sure that the child voids before going home. And if they need anything for discomfort, they can just give them some Tylenol. All right, so now we're going to talk about phimosis versus paraphimosis. So at the top, well, first of all, phimosis in itself is a narrowing of the prepudal opening of the foreskin. So you can see this. Let me grab a pen real quick. Where's my pens? We need a different color because this is a red background. I think I'm going to grab yellow. Hopefully you can see that. All right, so this is the prepuce, and it is very narrow. So you're not going to be able to retract the foreskin. All right, and so this is what I was talking about earlier, that normally we can retract nicely back across the gland, but when you have a very narrowed area, you're not able to do that. You cannot force that. This is something that will resolve usually over time. We do use a steroid cream, and then we teach the family members to just kind of pull just a little bit gently every day and use the cream, and eventually they'll be able to retract the foreskin over time. However, if it does not do that, there actually could be some obstruction that occurs, and we might have to go in and surgically do it. So with paraphimosis, the difference between that and phimosis is with paraphimosis, there's a strangulation. So we're not really going to wait on that one. They're going to have to go in and go ahead and do the surgical procedure. So paraphimosis, which isn't talked about in your book, I want you to know that that actually is something that requires surgery, because there's a strangulation on the penis gland, and that actually can cause some necrosis, and it could be a life-threatening situation. So we need to make sure that surgery is done if it is a paraphimosis. And you will not see urine output, and there will be discoloration and lack of blood flow to the penis. Okay, so for hernias and hydrocele. So hydrocele specifically, let's talk about them first. Basically, this is just fluid from the abdominal cavity that has flowed down into the scrotum or the scrotal sac. This is very common to see in newborn boys. There are two types. We have communicating and non-communicating. So let's talk about why this happened first. So normally when the testes descend, when they descend down from the abdominal cavity, the cavity that they actually or the channel that they actually descend down actually closes. When this closure does not happen, that is when we start to have the fluid begin from the abdominal cavity, continues to flow down into the scrotum. That is called communicating. Kind of similar with communicating versus non-communicating hydrocephalus. But nonetheless, when we have communicating hydrocele, that means that it never closed. So the closure has not happened, and it's commonly seen also with inguinal hernias, which we'll talk about hernias in a second. Surgery is going to be needed for both if we definitely notice that it does not close, or it didn't close, or if it doesn't close on its own, because this is something that's not painful. We do need to monitor it. And if for non-communicating means that the closure did happen, so there's a temporary failure of the closure, and the fluid from the abdomen basically is leaked, that leak down in there is trapped. So we want to monitor to see if the body will just reabsorb it or take care of the fluid on its own. If that doesn't happen, then probably after a year, then they're going to go ahead and into the surgery. So so this again is not painful. I've taken care of infants who've had this. It looks bad to the parents. We just need to educate them on what actually is going on, and that this is easily resolved and can be resolved very quickly with surgery on the same day. Now, hernias, however, there are different type of hernias, and I put the page number for Silvestri, which is 411, if you want to take a look at that. I believe it's actually in your GI part of your Silvestri, because these two lectures go very nicely hand in hand. Hernias are basically a protrusion of bowel. So I'm going to use my cursor real quick. So you see here, this is a bowel that has actually gone through that canal where the testes have descended down into the scrotum, and this is an inguinal hernia. This is a hydrocele, so this is considered fluid, so to speak. So this white ball is actually the testes. So sometimes we can have bowel contents kind of prolapse down into the scrotum, or we can have fluid. All right, so it's important for us to be able to first see, is it fluid or is it bowels? Again, at the top, as you can see this right here, so we know which one it is because we use a transluminator, and when we light up the scrotum, we see this transient light color. We know that that's fluid. However, if this was bowel, this would be a very dark fluid. All right, that's how we know whether we're dealing with bowel or whether we're dealing with fluid. Now, with an inguinal hernia, which is the bowel, we need to be very careful because we don't want strangulation of the bowel. So this is definitely going to need to have surgery, because we're going to need to close the canal and put the bowel in the right spot. Once the child has this type of surgery for an inguinal hernia, we usually give them some ice, some cool compresses to the area as tolerated. The children are not able to strain. We say this with adults too, but for children, it means that we have to probably put them on something so that their stooling is very easy, because children can get very dehydrated. Listen, can get constipated, especially if we put them on polybisol or some other medications, and we don't want a child straining who has had a hernia surgery. So we're going to probably add a laxative to the regimen until the hernia repair is completed. And also we tell families to not give them a tub bath until it fully heals. So they'll have to just get a regular sponge bath. All right, next we're going to talk about cryptochiasm. I think I said that correctly. So this is basically a failure of one or both of the testes to descend normally through the inguinal canal. Okay, so remember I talked about on our assessment that we need to palpate to see, to make sure that the testes descended. If they didn't descend, then basically we will wait on it, and if not, then they'll go to a urologist to rectify the situation. Very simple. And the procedure that they do is an orchoplexy procedure, and is completed before 1 year of age. Okay, so bladder estrophy, this is a birth defect. Sometimes epispadis is also seen with this, and basically the bladder is born outside of the body. So this is an impairment or an impaired fetal development in utero. This can also include reproductive organs that are born with outside of the body, some muscular like cavity contents as well. So bladder, muscle, reproductive organs, altered development of the penis as well. And this can happen to girls as well as boys. And so definitely a specialist would have to come and take a look at and give us a clear understanding of what we're looking at. Most likely we will know this beforehand if the child had adequate prenatal care. Excuse me. But the abdominal and anterior bladder wall fail to fuse, and they are born with, let me get my cursor, with the bladder. This isn't a great picture, but the bladder is outside, and you can see this is the bladder. The really red structure is the bladder. Figure 24.7 and 24.8, they have some good pictures as well. You'll constantly have seepage of urine, so it's going to be very hard to estimate what is the child's output. This is something where we're going to obviously have the wet gauzes available, same thing we did with spina bifida. We're not obviously going to cath this child because the child's bladder is outside of the body, so there's going to be constant seepage of urine. We have to try to find some way to measure it or get some idea. Usually if we just sit the child on the diaper and we allow the urine to kind of go down, we can just do it that way. Surgical closure is within the first 72 hours of life. And the big thing is whenever you have exposed organs, they're at higher risk for infection, and they're at higher risk for thermoregulation issues as well. Hypospadis and epispadis. These basically are disorders of where the urethral opening is located along the ventral surface of the penile shaft. All right, so for hypospadis, it's located along the ventral surface. For epispadis, it's located on the dorsal surface. All right, and we have some great pictures here to show you. So here's epispadis. All right, and then here is hypospadis. Circumcisions usually are delayed with both of these conditions because we need to have enough foreskin in order to do the full surgical correction. And they usually want the urethral lengthening to happen, so they want some growth in the penis to occur before actually doing it. Postoperative care for this, basically we want to decrease any chances of infection. We want to monitor the urine output because anytime we mess with the gland or the urethral openings, we have a chance for obstruction. And then this does cause some pain and spasms. So spasms, we want to look specifically at any output changes, and then make sure the child gets pain. And usually it's just Tylenol, nothing really, really strong, because this is usually repaired within the first year of life. So disorders of sexual development. This is really interesting. Now, I want to let you know that it looks like my picture is covering it a little bit. You can move my picture around so you can see things. I will tell you, this is a really good picture of when we're not clear if it's a boy or a girl. And this has happened to me a couple of times when I've gone down for births. And it's a really difficult situation to be in. Because you don't know what to say, but you can't hide the question everybody wants to know when they're born. Is it a boy? Is it a girl? And usually, I haven't been the one to actually respond to it, but usually it's the doctor who's with me or the resident, and they kind of explain to them, at this point, it's kind of unclear. And they say, I'm going to have my attending come and talk to you a little bit more. But in the meantime, enjoy your newborn. So, the baby presents at birth and we have ambiguous genitalia, and it's very hard for the family to see that or to hear that. Sometimes some of the common things we see is bifid scrotums. They usually do have a micropenis. They have unilateral gonads or testes, and we don't really see what's going on for our females. The labial may be fused, and then their clitoris will be very swollen, which we may think is a penis until we look a little bit closer and we're like, no, that's not a penis, that is a clitoris. So we need to be very mindful and very clear about whether this is a girl or boy. If we have any uncertainty, then we need to defer. It's very rare that this happens, but it does happen. And in some undeveloped countries where it happens, there are adults who actually are fully developed, and they walk around and they have pretty much both genitalia, or they have ambiguous genitalia, and it is traumatizing. I did not show you the pictures here that are out there, but I know of several incidents where people had to have reconstructive surgery, came to the U.S. so that they can get reconstructive surgery to be who they are. So now let's talk about how we identify this child before they go home. That is up to the parents. We can do some tests, genetic tests, to see, really what is this, more of a girl or a boy. There have been times where the tests have come back kind of some genetic anomalies, so to speak. And the family or families have raised a child as a girl or a boy, and they got genetic tests later on, because it's kind of hard to do hormone tests, because we like to do hormone tests in addition to genetic tests, but we can't do it right after birth. So the final conclusion happens a little bit later, and the family needs to decide whether they're going to allow raise this child as a girl or a boy. In today's society, I just know of one family that said, we're going to let the child decide. And I'm not sure if I agree with that 100%. I understand where they're coming from, but I'm also thinking about the development of that child as they grow, not really understanding who they are and being guided in a direction. And we have the means to be able to say what you physically are. But there are times that children have been raised as a girl or a boy, and they did not feel like that. And I really believe it has a lot to do with disorders of sexual development, that we find out later on, like, oh yeah, when you were born, this is what happened. However, we decided to raise you as a girl, and come to find out, like, well, I don't feel like I'm a girl. And they actually had some characteristics of the other sex that were eliminated, but eventually came out in other ways later on. So the whole thing about this is we need to support the family. We need to tell the truth at birth. We need to hopefully get some resolution to this, but we can't put pressure on them. We can only help them guide their decision and support them throughout their lives. It's a tough situation. I also want to mention that congenital adrenal hyperplasia, CAH, is a sodium wasting condition that is life-threatening. But usually when we see children with disorders of sexual development or sex development, is highly correlated with that condition. So if we see ambiguous genitalia, we need to have that child screen pretty fast, because they have probably a couple weeks before they are in a life-threatening situation, if not sooner. It is also a condition that's found on a metabolic screening panel, but we cannot rely on them to be able to identify it and let us know for numerous reasons, which I'm not going to get into. But if we do see a child with disorder of sex development, we need to make sure that we screen them for congenital adrenal hyperplasia. All right, next we're going to talk about enuresis. So this is also called bedwetting or incontinence. It usually does happen at night. Some of the causes are usually related from a psychological issue the child is going under, or an enormous amount of stress, which could be anything. It could be move, it could be school, it could be peer pressure, it could be abuse. It could be a physical issue, like the child is having bladder spasms or having reoccurring UTIs, so they're having urinary frequency. A child could also have a neurogenic bladder. They don't need to be congenitally or have a congenital anomaly or have CP in order to have a neurogenic bladder. So we have two types. We have primary versus secondary. Primary, we describe it if the child was never toilet trained. So if they've never achieved incontinence, meaning they've been potty trained, then we call that primary. If it's secondary, if they have achieved potty training and for at least 3 months, and then they end up going backwards and having some bedwetting, or and wetting can happen during the day or during the night. So don't think of it only as like a nighttime thing. Nocturnal, obviously that's specifically just for the nighttime. So there's certain things that we can have the families do to kind of stop this from happening, limiting the amount of fluids at a particular time during the evening, making sure that they go to the bathroom before going to bed, and making sure that they completely empty their bladder. Diurnal means that it's happening day and night. Okay, so these are the types: primary versus secondary, and whether it's nocturnal or versus diurnal, which is day and night. So another management that we do, because we don't want a child to be necessarily dehydrated, people worried about that happening, we want them to schedule a system. Usually we encourage them to increase their fluids during the day, and then I told you about what we would do at night. Make sure the parents know not to scold their children. Sometimes this is truly possibly a physical issue or something psychological that the child needs to get over. So we don't want them to, punish the child. Let's work together to figure out how we can make this less embarrassing, especially if it's during the day, and less disruptive to the family needs if it's happening during the night. There are some medications like DDAVP, which we talked about in endocrine, that can actually kind of dry up the child. We've talked about this before, because we use it for DI. So it basically, if somebody's in DI, it would actually help the child calm down, and you will not, their output will be diminished. But you got to be very careful with DDAVP. All right, so next, you'll see this video, which is the video I talked about before, that is from Khan Academy. And I love right here, as you can see my cursor, is where we have that Bowman space. And that is where a lot of the conditions that we're going to talk about in a minute happen. Now, there are some other areas too, but I think he does a really good job. Hold on, get this go away. He does a really good job of showing and explaining, all the filtration and stuff like that. It's not too intense, but it's just enough to really help you see clearly. So make sure you take a look at that just for a quick review. All right, so we're going to touch on UTIs. We talked about it just a little bit in the beginning, but it's one of the most common conditions of childhood. Most children will have a UTI in the first 2 years of their lives. Febrile UTI is just that. They have a UTI that's which is associated with fever. Some are not associated with fever, so make sure you know the difference between the two. The most important issue is that they're not eliminating all the urine, or they're having retention, or this could be some urinary stasis going on. We already talked about how uncircumcised males are at higher risk and why. Females are at higher risk after 12 months of age, and the reason why is because of shorter urethra. And E. coli is the most common agent, and it's also one of the most common agents in adulthood too. So just make sure you pay attention to that. Some of the manifestations or signs and symptoms that you'll see, it will depend on the age of the child. Urinary frequency is a very common one across all ages. They'll have frequent urination, excuse me. It's very hard to tell that though with an infant because they pee all the time, right? We want them to pee. But it's really looking at that odor, looking at how they react when they periodically, like, they seem like they're in pain, and then it seems like they always do it. They cry when they go to the bathroom. Sometimes you might see some blood, specks of blood or traces of blood in the urine in the diaper. So that is a red flag. And diaper rash. So when you have a UTI, the pH changes, and that actually causes, and we talked about this in the first section, that actually can cause, we talked about it for diarrhea standpoint, but the same thing can happen from urine. When the pH state changes to a more alkaline nature, it actually can cause breakdown of skin integrity, and then they can actually have more diaper rashes. Let's see here. Let me see if I missed anything. Okay, I think that's about the classic signs. Again, not that different, but you have to pay attention to when you're looking for signs and symptoms with a child, depending on their age. All right, so classification. So we've got asymptomatic versus symptomatic. And so that really symptomatic is having that fever, having that changes in urine. Pyuria speaks to pus in the urine. You know, if you have, well, we'll talk about that in a minute. I was going to say if you're spilling protein, it's going to be frothy, but we'll talk about that in a second. Upper tract infection involves the pelvis, the urethras, and the renal parenchyma. I think I'm saying that right, guys. And then the lower tract obviously involves the lower urinary tract, which is the bladder, and the urethra. The rest of this is pretty straightforward. Just know that pyelonephritis is when you have a kidney infection. Okay, pyelonephritis is when you have kidney infection, and it usually is associated with also the child having frequent febrile UTIs. Urosepsis, however, is when the bacteria that has been infecting the renal system or the urinary system has now seeped out into the systemic and is in the bloodstream. So it is the cause of a septic event, and so urosepsis is the name that we call that. All right, so UTI nursing education. This is, you won't find this in your book. This is in another book, but I think it's really good. This is the education that we focus on. We talked about some of this stuff in the beginning, but you also want to try cranberry juice to make it more acidic versus alkalic. But sometimes children will not take cranberry juice, so there actually are some cranberry chewables or cranberry pills if they're older, which work really well to help combat UTIs. You want to make sure they drink enough fluid. You want to avoid caffeine drinks and things that can irritate the bladder. Avoid bubble baths. Some kids like bubble baths and sit in the bubble bath forever. My daughter was like that. But the soap can actually become very irritating. And when you irritate the normal flora, then you basically increase the chances of a UTI. We talked about wiping, wearing cotton underwear versus some other underwear. I don't know what else is out there, but I'm sure there's some type of like nylon or synthetic. We definitely don't want children wearing that. We want something breathable. Avoid wearing tight jeans or pants, no skinny jeans. I laugh at that because that really does contribute to UTIs. It's a long story, but wearing tight clothing is not really good when you're trying to prevent UTIs. And then while menstruating, for our teenagers, they need to change their pads and make sure that they also, I think, I want to say change tampons, but I don't think that increases their chances of UTI. I think it's more of if they use pads versus tampons. Okay. And they have your void immediately after sexual intercourse. That is across the board for our females and for our males, but it's always good if you have a teenager who's having a recurrent UTIs and we know that they're sexually active, and they told us that that is something that we need to make sure that they do. All right, so now we're going to talk about some urinary catheterization methods and the bundles. So with this right here, you'll see different ways that we can get urine from children. Obviously, we want to try the most non-invasive way as possible. So right here, I'm going to use my cursor. Right here is our bag approach, and it's a very common approach. It's like getting a clean catch on an adult. And we just basically stick the bag right over, well, this is a female, right? So right over the labia, and then there is a small area between, I think, the vagina and the urethra. You can't see it really well, but there's a piece of tape right here that we have to actually put it there, because if we just kind of put it on the child, they may pee actually outside of the bag, and then no urine will actually go into the bag. So we have the U bag, and then we have the next step would be, obviously we can do a clean catch if the child's cooperative, or we'll do the U bag. Make sure you know the difference between intermittent and dwelling. Intermittent is when we basically are going to go in. So up here is a picture of an infant getting cath with an NG tube, because we usually don't have Foley catheters that are small enough for our infants. So we use a sterile NG tube, and we catch it in a sterile container, not a bowl. We would actually use a cup, a sterile cup, and they are catheting a female, I can see. The next thing is the urinary diversion. So here you see a stoma. We talked about that before. We talked about the ACE in the GI, but this is a urostomy opening. So this is a stoma opening that a child will cath themselves through this stoma, and it will actually it'll go. The urine is sitting right in here, and they'll basically cath themselves. So this is the ileal conduct. So this is obviously surgically created, and that is another way that we get urine from children who have had to have some augmentation done. And then last, this is pretty invasive. I've never seen anybody successful doing this, and this is a subpubic or suprapubic needle. They go in directly into the bladder and take out any urine. That is very painful. I've seen this done on an infant with a physician who was unsuccessful, but we tried, and that is another way. But obviously that's very invasive, and they're high risk for infection, not to mention you can hit some other things as well. And dwelling is obviously our Foleys, which we're going to talk about next. So with our dwelling catheters, I mean they dwell and they sit in the bladder and drain to gravity. We all know about that, but we need to make sure that we're clear about what a Caudy bundle is. And it includes all of these different things, and I hope that nothing has changed. So we're going to go by what's on here on the slide for the test. So when you talk about a Caudy bundle, we're basically trying to prevent what we consider a never event, which is a child getting a catheter-associated UTI due to the fact of having a catheter in there for a long period of time. So the first thing on the bundle is you need to assess whether or not they even need it. So when a nurse comes on and they're getting a report, and they find out that the child has a Foley, there may be situations where you're like, why does the child still have a Foley? They don't really need a Foley. And so we need to assess every shift whether or not the child needs to have a Foley. That's number one. Make sure that only people who are trained on the technique of putting in a Foley sterilely, properly, actually do that. We need to maintain aseptic technique during the insertion. If at any time something changes, then we need to start over. We need to make sure that there are no kinks or loops in the whole system, even the drainage system that goes down to the bag. Make sure that nothing is kinking it. Make sure it's not sitting on the floor. And make sure it's below the level of the bladder, because if it's going by gravity, it can't drain if you're laying it on the bed where the bladder is pretty much level to it. So it has to hang below. If you feel like they do not need it, nurse is able to remove it. So yes, at Children's Healthcare of Atlanta, we are able to remove that Foley automatically if the child doesn't need it. Do I call the physician and say, hey, I'm about to remove the Foley. Do you have anything that I don't know that I need to know so that I don't do it? And they're usually like, yeah, you can go ahead and do it. And then collect specimens and flush only when indicated. Now, flushing is flushing is something we can do, and because sometimes children have sediment in their urine, and so the catheter can get kinked, but it's not something we commonly do because you still have to do a whole sterile procedure, so you have to be careful about that. Another thing is that if you do go through the port, usually there's a port on the tubing that goes to the drainage bag where you can collect specimens. You need to make sure you clean it with CHG or whatever solution and collect it sterilely, just like if you were drawing a blood culture off of something, because if you don't do it, then you're probably going to introduce a bacteria into the catheter, and it will go up into the urinary system. All right, next we're going to talk about some conditions. So these are the conditions I want you to focus on, and I created a chart for you, and you're going to see that in a minute. You will not have it on your slides, but I will post that chart in Canvas so you have access to it. And it's just a general chart. It's nothing absolute. It's just a nice chart where you can look at all of them and help you study. So we're going to kind of go a little bit backwards. The chart goes in the other way, but we're going to go backwards this way. So VUR, so basically this is when a child has a disorder of the flow of urine refluxes back into the urethras. This can cause a lot of problems. We're going to look at the grades in just a second. But if you have a backflow into the into the urethras, that actually can cause dilatation and actually UTIs as well as kidney disease. So when urine is swept back into the urethras, it basically can go all the way back to the kidneys, but basically it just sits in there and it creates a place for bacterial growth until the next void. This is one of the main causes for pyelonephritis and, like I said, febrile UTIs. The next one shows just the two different types. You got primary versus secondary, pretty straightforward. Primary is a congenital abnormal insertion of the urethras into the bladder. So the child is born with that. Secondary is a result of an acquired condition. All right. And then let's take a look at this next slide real quick so you can see the grades. So they're graded all the way from 1 to 5. As you get to 5, you see a larger dilatation of the urethra, as well as backing up into the pelvis of the kidney, and so forth. And it's actually affecting the kidney. So remember that VCUG that we talked about? So this is how they will diagnose the grade of the VUR. So the more severe it is, it would be grade 5, which pretty much they're going to have to do some pretty good intervention pretty quickly. All right, so let's talk about treatment. There we go. Oh, did I get? Okay, there we go. All right, sorry about that. All right, so with management, we basically want to prevent this from happening. We would prevent any bacteria from reaching the kidneys, and we would prevent any bacteria within the urinary tract system anyhow. Practice double voiding. So double voiding is a technique where after a child voids, what we tell them to do, and I'm going to scoot back for a second, we tell them to, after they void, they lean forward, and what they're really doing is that they're providing their own what we call credé. In the hospital, we credé, and so let's pretend that this is a bladder, a child's, abdomen, lower abdomen. So what we do in nursing, we actually go, and so this is the bottom of their pelvis, and so what we do is we go in and we press down, and this is called credaying. When you creday, you're basically trying to get out any type of urine that is remaining in the bladder. So when they go home, we're obviously not going to be able to do that. We can teach the parents that if they're being cathed, but we also teach the children how after you finish going to the bathroom, before you wipe yourself, go a little bit front, bend over, and then try to bear down to pee. And it works very well. It's a technique I tell a lot of females to do too, and I have actually done it myself just to make sure that I have voided completely. Also, talk to them about avoid holding their urine, put them on a schedule, getting a urine culture every 2 to 3 months just to monitor the growth or their urinalysis. And then, of course, if the child develops a fever, we're going to need to go ahead and do a culture. We already talked about the VCUG, and children usually do very well, but the severe forms are going to have to have surgery. All right, next we have nephrotic syndrome. Nephrotic syndrome predominantly occurs in children in the preschool and school age. There are 3 types. You got idiopathic, congenital, and secondary. Same thing. Whenever you hear the word secondary, it's usually due to another condition that has caused this problem. All right. Idiopathic obviously means we have no idea, and that does happen sometimes. We don't know why the child has developed nephrotic syndrome or whatever condition. And congenital means that they were born with it for whatever reason. This is one of the most common presentation of glomerular injury in children. The idiopathic is mostly associated with minimal change nephrotic syndrome. Excuse me. And this is obviously at the glomerular level. And there is an increase in permeability of proteins. So just remember, if you have an increased permeability of proteins, that means you're spilling a lot of proteins, so you're going to have massive proteinuria. You're also going to decrease the amount of protein in your bloodstream, so hypoalbuminemia. And so because you're spilling all these proteins. And I'm going to show you my chart later on because it goes into a little bit more detail. You're also spilling some lipids, as well as some other elements, and you're creating a huge edema situation in the child. So you can see this child in the picture here that had that periorbital edema. They have that kind of puffy face, and they're also edematous in other places as well. They're miserable, by the way. They're very fatigued. They also have ascites as well, and that is because of the edema, as well as the shift in osmotic pressure and the wasting that they're having. So because you have spilling of proteins, you're going to have that foamy, frothy urine that I talked about before. Okay, foamy, frothy urine. All right, so let's move on to some more management of this situation. First of all, always be supportive. Their diet is going to be in low fat, high protein, even though protein, if they are in a severe situation, the protein isn't going to help as much, but it's always good to give their body some more protein. They're going to have strict I's and O's. We're going to put them on steroids because this is an inflammatory situation. So we also might have to put them on immunosuppressant therapy as well. If necessary, we might need to catheterize them. We might put them on Lasix as well, but we have to be careful about that. Monitor their weight, edema, check if they have ascites. We're going to measure their abdominal girth daily. And pretty much the child this can resolve, but we're going to have to monitor them probably for the next couple months. All right, AGN or APSG. This basically is glomerulonephritis. So we are having a infection or inflammatory process after having a strep infection. Okay, sometimes it isn't associated with a strep infection. Sometimes it could be other conditions that could cause it, like sickle cell or lupus. But pretty much it's associated with having a strep infection. In this one, you're going to have spilling of protein as well. You're going to have cast, and you're going to see white blood cells. You're going to see red blood cells in their urine, and you're going to have bloody urine. So they're going to have generalized edema as well due to the decreased glomerular filtration. They're going to be very hypertensive due to increased extracellular fluids. They might actually have very minimum urine output, so we have to monitor that. The urine is going to look like Coca-Cola because of the blood that is in the urine, and because of all of the protein is also going to be frothy. I call it HUS, but hemolytic uremic syndrome. This one is mostly associated with E. coli infection, but it's not necessarily a UTI infection. It could be the child didn't eat, child received food that's not well cooked, so it can be an ingestion, a GI issue that reached the kidneys, and now they have hemolytic uremic syndrome. The last case that I saw of this was the swimming pool. So this was well water that the family swam in that was E. coli infested. We've heard some infections with people going and swimming in the Chattahoochee that has a lot of E. coli at times, especially after lots of rain, and they end up developing hemolytic uremic syndrome. So it's really important to know the levels of E. coli. If you're going to use well water or anything that is not chemically balanced, you need to know the nature of bacteria in that water. Okay, moving on. There are three classic signs with this. Hemolytic anemia, so they're going to be very anemic. Thrombocytopenia and renal failure. All right, so with this, these are the three signs you're going to see. And this is why I love doing GI/GU last, because a lot of what we talked about, anemia, also you're going to have renal failure, platelets being low. You already know about this stuff. And so when you get your questions, you need to make sure that you understand if you see anemia again, or thrombocytopenia, which is low platelets, or whatever the case may be, you know our management for that. Because my questions aren't that straightforward. What are the three common signs of hemolytic uremic syndrome? Right? I might have a question like that, but really it's going to be, okay, so what would the nurse expect to do? Well, I expect to give platelets. I'd expect to give transfusions. And if it's severe, we're going to have to put them on dialysis because we have renal failure, right? And so that's what I'm looking for. All right, and maybe a little bit more. All right, it's common in younger children, not the school age, where the other one was school age. It's common in younger children, 6 months to 3 years. We already talked about is associated with E. coli, which is diarrheal illness. E. coli, it's a nasty bug. And so with these children, you'll hear that they've had a history of having days of diarrhea or bloody diarrhea. They may or may not have been diagnosed as E. coli. All right. Here, the glomerulus becomes occluded with platelets and fibrin clots. So it's a very, we call it, the way that a lot of people call it who do CVVH, which is hemodialysis, they say that the filtration system it's all sticky, and it just has all these platelets and blood and fibrin clots in there. And so think of it as a sticky mesh, and nothing is really getting through, which is why they lead to renal failure. So you're going to see elevated blood and creatinine levels because nothing is being filtered. Usually, if we have no urine for at least 24 hours, we're going to put them on dialysis. So think about what are your nursing considerations if this happens. How do we prevent this? So if the source is E. coli, cooking food properly, washing your hands, making sure they use the right diapers when they go swimming, because swimming pools become infested because people don't use the right diapers. and child goes to the bathroom or stools in a pool, and then now you have E. coli in the pool. So that's why anytime anybody has an accident, so to speak, a stooling accident in the pools, I don't know if you guys have witnessed that, they have to shut down the pool completely and do it all over again because of the high chance of E. coli. Make sure they wash everything before they eat it, and that includes vegetables and fruit. Some nursing considerations here, and you're going to see this a little bit more in the chart coming up. Nursing considerations, if we have renal failure, guys, you know automatically we're going to have blood pressure issues, right? So we're going to be hypertensive. If we have low platelets, right, we're going to have bleeding issues. We're going to have electrolyte issues because no filtration's going on. We're going to have fluid issues. So we're going to have to, if we have electrolyte issues, we're going to have sodium issues, we're going to have potassium issues. So we're going to have to monitor them for seizures as well as arrhythmias, and then also the urine output. All right, so let's take a look at the chart here. The chart, hopefully you can see it. You can blow it up later on, or again, you can just pull it off a canvas. I have nephrotic syndrome up here, and I talk about the fact that MCNS is the primary one for nephrotic syndrome. I talk about, so I have the disorder here, I have the urinalysis, the signs and symptoms, what area is affected in the kidney, what is the patho associated, and what are some of the things you need to think about. So nephrotic syndrome, for example, proteinuria, they have that dark frothy urine, which I just talked about. You know why. I said dark here, but cola. Then we have weight gain, low urine output, ascites, periodemia, blah, 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 loss of appetite. And then the affected area is the glomerular membrane, which is why I'm strongly suggesting that you look at that Khan Academy video. He talks about that space in the different membranes. The patho is basically increased permeability of protein, albumin, and lipids. So those things are just dumping all the way through. They're not even being filtered, because in the video he talks about how they are not allowed to filter through, but in this particular nephrotic syndrome they are allowed to filter through because of the increased permeability. All right, so here, and then we said this was more of an immune issue, right? Might have to put on antisuppressants. I think I'm saying that wrong, but immune suppressants, and steroids. So steroids are here. Diet. Make sure you pay attention to the diet. So, all right. And your book does a good job of explaining it too, but they're not straightforward. So here's the deal. They have a decreased appetite. Children feel like crap when they have these conditions. We don't limit them. If they're in the mood to eat or drink, we let them. Of course, we're not going to have them have Doritos, right? But they can eat. They can eat something. We just don't add salt to it. I already talked about putting them on a high protein diet. If they want it, let them have it, because they feel so bad. Anytime they eat something, we're happy that they're eating something, because they usually don't eat much at all. And they usually are on TPN and lipids. All right, so APSGN, sorry. This, again, here's what your urinalysis is going to look like. Here are your signs and symptoms. Make note that, the irritability associated with this because of their sodium levels, which increases their chances of having seizures. We talked about that before. This is an inflammation of the glomerular capillaries. And this is the patho for that is the plasma is not being filtered. It's increase of fluid and sodium. All right, so regular diet, monitor lab values for restrictions, based on restrictions, antibiotics. If it's strep related, we need to do that. And remember, but it could be related to something else like sickle cell, and diuretics if not in renal failure. We can't put somebody on diuretics and have them wanting them to diurese and take off fluid if the kidneys can't manage it. So we can't give diuretics if somebody's in renal failure. So do not select diuretics if it says that the child is in renal failure. All right. Okay, in HUS, we talked about that being E. coli. So it says sugar-like toxin. Well, that's the toxin that is a result of E. coli. And I posted a video for you. I thought that that video was really good. It's a case study of a real case of a child coming in with HUS. And it's nice to listen to the ground rounds or the rounds of the physician and so forth to kind of, see a little bit more about that. This one, because we have a lot of casts. Remember, we have casts in the urine. And I think, so where's my urinalysis? Do I have casts? Yes, I do have casts. Just making sure I have casts there. We're going to have to transfuse, right? And we're also thinking about putting this child on dialysis. The last two is our hydronephrosis and our VUR. So remember, hydronephrosis is an obstruction, and I didn't have necessarily a slide on that, but it is an obstruction, and it's not necessarily like a kidney stone or anything like that, even though they could cause it. But it's somewhere obstruction in the urethers or in the bladder, somewhere in the urinary tract. There's some inflammation, or the valves or the junctions are not operating properly. So because of that, urine can't flow normally. So this is not something where we're going to monitor a urinalysis for both of these. This is something where you're going to see certain signs and symptoms. So you're going to have urinary stasis. You're going to have frequent UTIs possibly. This could also be associated with fetal, I think it's ogliohydramnios. And that is basically a low level of fetal fluid. They can diagnose that before the child is born. Because remember, the child voids when they're in utero. So when we have low levels of fetal fluid, that could be the fact that they have hydronephrosis. All right. So anyhow, basically the treatment for this is they need to do a valve ablation. So they need to open up that valve or that junction. We need to, and sometimes they might have to put some stents in. And then if it doesn't work out, remember that stoma on that abdomen where we can collect urine, they might have to make a urinary diversion device or some type of conduct in order to be able to eliminate the urine from the system. And VUR, we already talked about it, so I'm not going to go over it here again, but I hope you find that this chart is helpful. Clearly, these are things that I want you to focus on, but make sure that you also read about these. These are going to be the only ones that you need to focus on. Do not waste your time reading something else. And don't forget about UTI. All right, so renal failure. So with renal failure, I just want you to understand the differences between acute versus chronic. Acute is not common in children. There are three types: pre-renal, intrinsic, and post-renal failure. No, you don't have to go back to med-surg and remember that. But the principal feature is basically that they have low or no outputs. I don't have both of the words there, but low or no outputs. It is reversible, so they have not gone to the point where they need to be put on the transplant list. Most common cause is usually severe dehydration or decreasing kidney perfusion. So there's something that's the kidneys are not being properly perfused, so they're not going to filtrate well, or the child does not have any fluid because they're so severely dehydrated. All right, chronic renal failure, however, begins when diseased kidneys cannot manage or maintain the normal chemical structure of the body fluids. So that means that basically the filtration or the ability of the kidney to filter the blood breaks down. It basically is going to progress to a clinical syndrome called uremia, which is why we follow the BUN. And it occurs when more than 50% of the kidney is destroyed. Here are some of the signs and symptoms. Obviously, for when you're in renal failure, we're going to have a lot of alterations in our electrolytes. They are going to feel horrible. Like I said, they're not going to want to eat, so they have a lot of nausea and vomiting. Like we get really excited when they want to eat something because that's great. Hypertension is always going to come into play. We are going to definitely place a Foley because they have strict strict output measurements, I should say. And daily weight, and we need to monitor them for lots of things, not just necessary output, arrhythmias, seizures, irritability, cerebral edema, and then also sometimes for CBCs, depending on what we're dealing with. Some of the complications are listed here. I'm not going to beat a dead horse. I've kind of already talked about that, so make sure you read on that. So the two devices, the two ways that we will do dialysis. Peritoneal dialysis is the preferred method for children. It can be done overnight. It's a very gentle way. I don't know if you guys have ever seen this done. I did it like for weeks on one child. I was a peritoneal person. I'll pull to the TICU to do this. But it is a nice, slow process. They do have a, I call it a VAS cath, but it's dwelling in their abdominal, in their abdomen versus over, well, in the next one you'll see a true VAS cath. So they have a catheter and basically there's a dwelling time where the machine warms up the fluid, and there's a whole setting and everything, but it dwells the fluid into the abdominal cavity. There are special components in this fluid that has to come from pharmacy, that's ordered by the physician because they know how much of sodium, how much of potassium that they want to pull off the child. So this bag is configured in a way that will allow that to happen. So the inflow time, and that's the time, the slow amount of time that it takes for it to go into the child, and then the dwell time, I would clamp the catheter and let it sit there for whatever time it's ordered, and then I would unclamp, and then the bag right here is my drainage bag, and it would actually drain out the rest from the cavity, and it looks like pee. And when it's done, then it's all bio waste, and I have to measure everything and so forth, and then put it into the biohazard. Okay. We weigh the fluid before and after. So if I dwell in, let's say 100 in this bag, and then after I take off and it comes out to be 150 or whatever, that means that I also pulled off 50 fluids of water as well, which is what we want to, because we don't want them to be swollen. All right, I think that's really about it. I think that's a good description of peritoneal dialysis. The next one is hemodialysis, and it's actually the last one. There's a couple of things you need to know about hemodialysis just as a nurse. First of all, we know this is heme, so we do need, so this is actually blood. So there's an external system that blood is removed, goes through that machine, and it takes over what the kidney cannot do. It requires a special access, which we call a VAS cath. So usually in hospitals, we will get a child, they'll go to surgery and they'll get that VAS cath put in. And then if they're going to have to get dialysis long term, they don't go with the VAS cath, they'll probably have an AV graft. You guys are probably familiar with both of them as well, because they do that also in adults. Excuse me. And so this is just a heme dialysis. You don't need to necessarily know all that goes involved with it. But it's when a child is on dialysis, it's a 2 nurses on 1 child. I am not a dialysis nurse, but if I was taking care of a dialysis nurse, one of the nurses would be doing dialysis, and I would be handling all the antibiotics, all the other meds, all the other needs of that child, while they focus specifically on the dialysis. It's best suited for children who can be brought to dialysis facility 3 to 4 times a week, because it's a long time. They have to be there 4 to 6 hours. This is great because it achieves rapid correction of fluid and electrolyte abnormalities, versus peritoneal dialysis. It takes some time to make those corrections. So Every child, will figure out which one's going to be best suited for them. Just know that if a child is in danger, then we need a rapid correction of fluid and electrolyte, then we're going to do the heme. But if it's something that we can do slowly, peritoneal dialysis might work. But usually when they come to us, they're in an urgent situation and we have to do heme dialysis. And the last thing I want you to know is how the differences, this is a central line, but there's a difference with this, and this is a VAS cath. So VAS caths require 100 units of heparin to dwell in them. So normal CVLs is anywhere between 1 or 10 units of heparin, but VAS caths have 100. That could kill a kid. If that 100 units of heparin reaches that child's system, they could die. So when you are ever taking care of a VAS cath, you need to make sure that you, first of all, know what you're doing. And then two, they're on here, like on this little piece right here, it'll say it'll say 5 mLs. And so we know if the child is not hooked up to CVVH, then, which is dialysis, then we're going to need to, before we draw a sample off of it or connect the child or whatever, we have to pull back at least 5 mLs of fluid. Usually we'll do a whole lot more than that. We'll probably do 7. Because we need to make sure that we do not flush. You do not flush. We have stickers on it and everything. Do not flush this line. Because these lines clot very easily. They're a very large bore catheter. And that's why they require 100 units. But if that 100 units reach that child, we have a problem. Big problem. So you'll always want to make sure you pull back the 100 units of heparin before using that catheter. All right, so this concludes the GU lecture. If you guys have any questions, please let me know.